everybody. It's such a privilege for me on behalf of Cardiological Society of India, the national body, and also the Cardiological Society of India Chennai chapter. Such an honor to host this Cardiac Rhythm Council annual meeting in a digital platform. A very new experience, could be the trend in the future. And we have a galaxy of the experts of arrhythmia and heart failure uh, to be to be speaking to all of us. And I thank every one of them, including the moderators. And there is this group of at least 150, I understand, the delegates who have. Thank you, everybody. It's a pleasure. It's an honor in this. And today is the inaugural day of this so-called digital. And moderators, the best of the minds of India in the fields of electrophysiology and heart failure. And, my mentor, my teacher, and the most respected of the electrophysiologists in the country, Dr. Narasimhan, is going to be leading the team of the moderation today, and accompanied very ably by one of the experts, again, Dr. Raja Selvaraj, who is the professor and the head of the Department of Electrophysiology at the JIPMER Pondicherry, and my friend, and the innovative brains, Dr. R.D. Yadave, is also going to be giving company to Dr. Narasimhan. So may I request the moderator to take over and start this inaugural session. Thank you.
Thank you, Vilas. And it's indeed a great pleasure to have Dr. Sanjay Dixit along with us. And I, on behalf of both Heart Rhythm Society as well as my co-chairs, Dr. Raja and Dr. Yadave, would at the outset like to thank Sanjay for making this possible. Because some of you are from general cardiology, I'm forced to introduce Sanjay because most of the people in EP, it's redundant to introduce Sanjay. Probably every one of you would know him. He's the professor of cardiology and electrophysiology from UPenn. Had a very illustrious career throughout his medical school and thereafter in the US. And he has been currently serving as the director of electrophysiology department at the VA hospital, and he's a professor at the UPenn. He has numerous awards, rightfully so, very prestigious awards throughout his career. To name a few, there is this AstraZeneca David Hack Memorial Award in Cardiovascular Research, and ACCF Procter & Gamble Career Development Award for arrhythmias, and more importantly, Wharton Business School Executive Leadership Training Course awarded through Cooper Leadership Society. He has been on the planning committee of AHA, ACC, and World Congress in Cardiology. And he has been the reviewer for every single arrhythmia journal. He has been contributing immensely in terms of both original work, in terms of arrhythmias and ablation, and several review articles. And he has been helping to plan several of these programs of prestigious colleges like ACC and World Congress of Cardiology. And it's a great honor and a real pleasure to have Sanjay along with us. He'll be talking to us about the outflow tract arrhythmias. Welcome, Sanjay. Floor is yours.
Thank you, Narasimhan. That is very, very kind introduction, and appreciate that very much. Also want to thank Dr. Pandurangi and acknowledge the other chairs for this section, Dr. Yadav, Dr. Selvaraj. It's my privilege to be here, and the topic that I've been asked to speak on is outflow tract tachycardias. And I hope I can make it worth your time for all the audience members who are here today. So, as the name suggests, outflow tract tachycardias tend to arise from the outflow tract region, which is a fairly large area at the base of the heart and the top of the ventricles. But the majority of outflow tract tachycardias seem to originate from a much narrower location within this large region, and that includes the anterior septal aspect of the superior right ventricular outflow tract region, the cusps, which are very close to this location, and I'll show you that subsequently. The aortomitral continuity, which is this region between the mitral valve and the aortic valve, the top of the mitral annulus, and the adjoining epicardium. So why outflow tract tachycardias arise from this very narrow belt remains a question that we haven't completely answered. What we do, however, know about outflow tract tachycardias is that the mechanism underlying these arrhythmias is delayed after depolarization-mediated triggered activity. And whether this region in some ways can sustain that mechanism uniquely than other parts of the heart is a possible explanation why these tachycardias are confined to this location. But I want to just spend a few minutes here reviewing this particular slide, only because it has bearings on how we treat these tachycardias. So this is sort of a generic model that was developed based on the work done by Bruce Lerman and his colleagues in describing the mechanism underlying outflow tract tachycardia. So what we know about delayed after depolarization-mediated triggered activity is that it happens at the end of the repolarization phase when the cell is hyperpolarized and results from calcium overflow. So the calcium channel opens up to release a large amount of calcium ion, which causes DAD-mediated triggered activity. And that is mediated by cyclic AMP. So the more cyclic AMP, the more phosphorylation of protein kinase, the more will the calcium channel open and release the calcium ion. And this conversion of ATP to cyclic AMP is determined by the interplay of the inhibitory and the stimulatory proteins. And you can see the stimulatory proteins is activated by catecholamines, whereas adenosine and acetylcholine work on the inhibitory protein and clamp down on the cyclic AMP generation. So you can see how the interplay of these and the factors that influence them can have an impact on outflow tract tachycardias. So when we think about outflow tract tachycardias, what are the clinical characteristics of these arrhythmias? So I'm sure all of you who have taken care of patients with these tachycardias would appreciate that they seem to have a fairly wide presentation. You can have fairly young folks present with these arrhythmias, kids, or you can see them all the way out into the geriatric population. But if you really try to look at how the distribution is, it seems to have a bimodal distribution, either patients very young or in their middle age. And why that happens, we don't have an explanation. There are several theories about that possibility of what determines that, developmental versus age-related. They seem to be more often in women, and there are certain factors that seem to bring them up. So certainly all those things that increase your heart rate, whether it's exercise, stress, caffeine, that seems to perpetuate these arrhythmias. Interestingly, in women, there seems to be actually a stronger association with hormonal imbalance, and they seem to be much more prominent around menstrual cycles or the gestation phase of pregnancy, compared to obviously exercise being a bigger trigger in men. Now, the presentation of these arrhythmias can be wide-ranging. Patients can sometimes be highly symptomatic, palpitations. Sometimes they can present with pre-syncope. It is pretty rare for these arrhythmias to lead to frank syncope, which is good because that has implications in how we treat them. And then, of course, a large number of these patients are asymptomatic, and that has to be factored into the decision-making in terms of how we treat them. So thinking about the treatment and the management of outflow tract tachycardias, the fact that they happen in the majority of patients who have structurally normal heart, and most of the times they present as PVCs or non-sustained VT, we have the luxury of trial and error because they are usually not life-threatening. So as I showed you in that previous slide, the different ways in which the calcium channel is regulated, and that's how you can influence that development of the tachycardia and then treat the different stages of how cyclic AMP is determined. So beta blockers, as you would remember, that it works by counteracting the catecholamines on the stimulatory protein, and beta blockers can be quite effective for these arrhythmias. They don't necessarily get rid of them completely, but they may attenuate the burden and certainly make the patients feel a little better. Calcium channel blockers work on the last stage of the calcium ion release, and so they can actually have a synergistic effect with beta blockers. The challenge, however, is that it's sometimes hard to give both these drugs together because of the side effects that they can have. Most antiarrhythmic drugs are also fairly effective in the treatment of these arrhythmias. And if somebody presents with sustained VT, which is rare, then adenosine or can be used for acute termination. So for all the reasons that we talked about and how these arrhythmias are tolerated, ablation therapy is typically not offered as the first treatment option for these patients. And even though it's highly effective, and I'll show you in the subsequent slides how effective it is, nevertheless, it's reserved either for patients who have failed or are intolerant to these drugs. There is, however, a subgroup of patients with outflow tract tachycardias that develop cardiomyopathy because of the burden of these arrhythmias. And the data shows that if your PVC burden or arrhythmia burden is above 10%, more than 10,000 PVCs in 24 hours, then that seems to be a cutoff after which tachycardia-mediated cardiomyopathy is a real possibility in some patients. And so if a patient does have tachycardia-mediated cardiomyopathy, then ablation therapy is probably the best way to manage them because it is the most definitive and effective way to treat these arrhythmias. And the key to successful ablation is first to localize accurately where these tachycardias are coming from. The mechanism, as I said, is delayed after depolarization-mediated triggered activity, which means that the source of these arrhythmias is focal, just a small area. And if you can localize it, and then you can get your catheter to that spot, then usually energy delivery and the effect of energy delivery is pretty good. And so that's why ablation therapy seems to be quite effective. And the tools that we use for ablation therapy, most important is ECG, which can help us localize these tachycardias. And we'll go through that in the next few slides. So in just talking a little bit about the arrhythmia ablation experience at Penn, we are a fairly high volume center, and in this 20-year experience of more than 5,000 VT ablations, at least 40% of the cases that we do are in patients who have structurally normal heart or idiopathic ventricular arrhythmias. And within that group, the largest number of cases are patients with outflow tract tachycardia. So for us, it's actually a very important entity that we do a lot of ablations on. Now, our own experience in terms of how we've ablated these tachycardias, which is conceptualized and summarized in this slide, a 15-year experience from 1999 to 2015. What we have noticed is that in the early phase of our experience, a lot of these outflow tract tachycardias, the site that we were able to successfully ablate them from was in the right ventricular outflow tract region. But over time, what we've noticed is that now more and more of our patients are manifesting the site of origin of these tachycardias in non-RVO patients, particularly the aortic cusp region and the alveoli. And that becomes a little bit more challenging to map and ablate, but nevertheless, with the tools that we have been very successful in targeting these. But the important message of this slide is that you have to be cognizant that just because somebody has the classic manifestations of an outflow tract tachycardia, it does not necessarily mean that they are coming from the RVOT. And so the reason why that potentially happens is because of how close the structures in this region are. I showed you the heart model. It gave you some clues, but when you have these patients in the lab and you do orthogonal fluoroscopy and you have catheters in different parts of the outflow tract region, you can see the relative proximity. So in the first set of pictures, it shows how close the cusp region is to the RVOT. These two catheters are virtually touching, even though they are in different chambers. The middle picture shows a catheter in the cusp region and another catheter that's been advanced through the coronary sinus into the great cardiac vein, again showing you the epicardial aspect of the basal LV and very close to the cusp region. And then the last slide shows you how close you can get to the epicardial aspect of the basal LV by putting a catheter under the aortic valve and mapping the endocardial aspect of the left. So because of the proximity of all these locations, outflow tract tachycardias tend to have certain common features, and that is an inferior directed axis because they are at the top of the ventricles. And then depending how leftward and rightward they are, you can either have a left bundle branch block morphology, which is predominantly negative forces of the QRS complexes in lead V1, or a right bundle branch block morphology, which is predominantly positive forces of the QRS complexes in lead V1. So why these manifestations happen, I'll try to show you the reason for that. And so let's try to work through this slide. So at the very top is the depiction of the outflow tract region created using electroanatomic mapping. The aortic valve is in the center. The RVOT, the superior aspect of that, sits a little higher than the cusp region, and then the mitral valve is fairly close and at the same level as the cusp region. At the bottom here is a cartoon which kind of shows the same thing, but when you're looking down from the coronal aspect. The RVOT is a crescent which sits very close to the cusp region, with the superior anterior aspect close to the left coronary cusp, the posterior aspect close to the right coronary cusp. And this is an orientation as you travel from the right to the left side of the different structures that you encounter. And so what I'm going to show you here are base maps that are done from different aspects of the RVOT and the rest of the outflow tract region as you move from the right to the left. So the rightward most is the free wall of the RVOT. The next structure as you travel leftward is the septal aspect of the RVOT. And then the next structure is the right coronary cusp, followed by the interventricular septum, and then the left coronary cusp. And after that comes the AMC. So this is fairly intuitive. Now, the effect of going from right to left is manifest in what happens to the QRS complexes in lead V1 and the precordial transition. So when you're very rightward or on the free wall of the RVOT, you have left bundle branch block forces and a late precordial transition. Generally, any precordial transition that happens at V4 or after is typically considered late. When you travel from right to left, the precordial transition starts becoming earlier and earlier. But mind you, even when you're on the left side of the interventricular septum, the QRS complexes in V1 are still predominantly negative. But once you get past this location and get to the left coronary cusp, now you begin to see biphasic forces in V1. And once you get to the AMC, you have predominantly positive forces, although there may be a small Q. So that's how you can anticipate how these different locations create these ECG forces. Now, the same methodology can be used to appreciate QRS morphology with 12 lead ECG in the rest of the basal left ventricular endocardium. So once again, moving from the lateralmost aspect to the septalmost aspect. The lateral mitral annulus, top of the mitral annulus, AMC region, and the left interventricular septum. If you focus on lead V1, anything that is lateral to the AMC region will have monophasic RVs. AMC is the cutoff where you lose these initial negative forces. So one of the manifestations of AMC is a small Q followed by large R wave, with inferiorly directed forces, that's almost sine qua non. Now, lead 2 can also be helpful, and the inferior leads can be helpful. And this is just a manifestation of how high or low the location is. So anything that's on the lateralmost aspect or the medialmost aspect of the basal LV tends to be a little bit lower. And so in these two locations, you can have not as positive, but sometimes even negative forces in 2, 3. But for the rest of the locations, top of the mitral annulus, ANC region, you will have positive forces in 2, 3. And lead 1 can also be helpful, and we'll get into that a little bit more in the subsequent slides. So I guess one thing to keep in mind is that, I've talked about how these tachycardias manifest in the different leads, but the key to that is that the leads have to be correctly placed, particularly the chest leads, and especially leads V1 and V2. And so this is showing you what, if the leads are incorrectly placed, can do to the QRS morphology. So in this particular case, what we did is looked at when you move leads V1 and V2 from the traditional location, which is the fourth intercostal space on either sides of the sternum, to either one intercostal space above or one intercostal space below, how that can influence the QRS morphology. If you move the leads down an intercostal space, you see more of the heart, so you see more positive forces in leads V1 and V2. If you move the leads one intercostal space up from where they traditionally are, you see less of the heart, and so the negative forces become more. And the way this could influence the ECG morphology is because, as I showed you, typically something in the RVOT tends to have negative forces in the V1. But if that lead is incorrectly placed a little bit lower, then you may start seeing some positive forces in lead V1 that may make you think the tachycardia is coming from LVOT with the cusp, and vice versa if you move the leads one intercostal space up. Now, another lead, as I told you a slide ago, is lead 1, and how that can also help us localize tachycardia. This is particularly helpful when you're looking at the superior RVOT, where you still get a lot of these outflow tract tachycardias from. So the superior RVOT, and this is again an electroanatomic map, and you're looking from the head end into the RVOT region, can be divided into a free wall aspect, a septal aspect. And then you can also have an anterior aspect and a posterior aspect. And we use this numbering system at Penn to quickly try to, give a location rather than verbalizing it. So numbers 1 represent posterior aspect of the superior RVOT, whether it's on the free wall or the septal side. Number 3 represents anterior aspect in this particular location. And the point here is that if you focus just on lead 1, the base maps from the free wall and the septal aspect of the anterior RVOT tend to generate negative forces, whereas space maps from the posterior aspect of the RVOT tend to generate positive forces. So that's how you can further localize the tachycardia in the superior RVOT. Now, lead 1 also can be influenced if the limb leads are incorrect. So the typical position of the limb leads in doing an ECG is either on the extremity or the shoulder. But sometimes when these patients are put through a stress test, which is not an uncommon maneuver to bring out outflow tract tachycardias, oftentimes to reduce motion artifact, you move the leads anteriorly from the shoulder to the chest. And in doing so, you can shift the axis of lead 1 much more in front of the heart. And what that can do is, if a tachycardia is coming from the posterior RVOT, as is shown in this example, or a pace map is being performed from the posterior superior RVOT, as shown in the second example, this is what the forces should look like when the leads are correctly placed, which is positive forces in lead 1. However, moving these leads anteriorly to the chest, you can see completely changes the axis in lead 1, both for the tachycardia and the pace map. So if you're not paying attention to this, you can also get fooled into thinking that the tachycardia is coming from a different location. So those are things to keep in mind. Now, We'll talk now in the next 5 minutes about some of the regions that are very unique. So the cusp region is an important region because it sits very close to the RVOT. The right coronary cusp is in close proximity to the posterior aspect of the RVOT. The left coronary cusp is in close proximity to the anterior aspect. And so tachycardias originating from the cusp region can share features with RVOT region. And it is important to be able to discriminate that because mapping in the RVOT is very different from mapping in the cusp region, both in terms of the approach, potential complications, power delivery, etc., etc. So a good way to be able to differentiate these two locations using surface ECG is this particular criteria that was developed by my friend and colleague Ed Gershenfeld when he was here with us at Penn. So here are two examples of patients. Both have what looks like classic outflow tract tachycardias, positive forces into the AVF and left bundle morphology. So is this tachycardia originating in the RVOT or the cusp region? And that can be challenging just based on looking at the morphology of the tachycardia. But this is where he came up with this particular differentiating criteria where you plot the R to S ratio of sinus rhythm QRS complex in V2 versus the ventricular arrhythmia complexes in C. And after plotting this ratio, you come up with the number of that calculation. And in a series of 36 patients that we looked at for this paper, a cutoff value of 0.6 was highly predictive. So if this ratio was more than 0.6, then the tachycardia was very unlikely to become RVOT and more likely to become cusp region. Now, a simple rule for applying this formula may be that if you have left bundle branch block morphology and precordial transition is late by V4 or after, usually that's the RVOT. If the precordial transition is early by V2, it's generally V3. If the precordial transition is in V3, then you can use the ratio. So that's how you can potentially work in trying to localize these problems. Now, other challenges in mapping the outflow tract region. So one of these entities that a lot of us deal with and struggle to actually target is outflow tract tachycardias that originate from the summit. So the LV summit is this hypothetical region, which is a triangle.
Excuse me, doctor. I'm extremely sorry to interrupt you, sir. Your screen will be going off in next 2 minutes. Thank you.
Okay, I thought we started a little late, 2 minutes after the actual times. That's what I factored into my talk. But yeah, feel free to cut me off if you want to. So this is the way the LV summit triangle is created. It is the bifurcation of the left main into the LAD and the circumflex. The base of the triangle is formed by sort of an imaginary line and the first septal perforator. And the great cardiac vein travels through this triangle and bisects it into two regions, the septal basal and the lateral aspect. And what we found is that tachycardias that actually originate from the lateral aspect of this triangle, you can actually ablate them epicardially much more successfully than those that arise from the basal region. And the way you can differentiate them is, again, using certain ECG features. So the Q-wave ratio of AVL to AVR is greater than 1.8. That suggests a more lateral location. If the R to S ratio in lead V1 is greater than 2, that suggests a more lateral location. And if there's the lack of an initial Q-wave in lead V1, that also suggests lateral location. Now, again, just something to keep in mind, the summit region is on the epicardium. It's a relatively thick muscle dimension here. And so oftentimes to target this, you have to deliver a lot of power from adjacent locations, including the great cardiac vein, or in some cases, the septal aspect of the RVOT. When you do that, you just have to be mindful of the LAD that travels in that location, or if you're on the epicardial aspect, the great cardiac vein, you can also encounter the trifurcation of the epicardial acid. So that's the challenge. Some of the other things to keep in mind, the outflow tract region can have different locations based on the orientation of the heart. So the forces that you expect from the outflow tract region may be attenuated in older patients where the heart is a little bit more horizontal, and where the leads 2, 3, and AVF may not be as positive. Also, in some cases, outflow tract tachycardias can originate above the pulmonic valve. This was a very early experience reported in 2003. Since then, there have been larger series where there has been a demonstration of targeting these tachycardias above the pulmonic valve. Just sort of as a disclaimer, we have done over 682 patients in this paper that I showed you previously. I just want to show it to you again. In none of these patients we ever had to go above the pulmonic valve to ablate RVOT regions. And the point of this is that in our cumulative experience extending from 1999 to 2015, regardless of when we were doing these tachycardias, our acute procedural success was about 86%. And clinical success has also been roughly around that, regardless of whether we were using traditional tools, which is just fluoroscopy, versus electroanatomic mapping versus ICE. The only difference is in our more recent experience, we seem to be requiring less repeat ablation, and the complication rates for our tachycardias, ablating them has been about 2%. So, just to make the point that catheter ablation is highly effective, and in order to be able to perform it, you have to do careful analysis of the ECG as the first step. And then using tools like electroanatomic mapping and ICE imaging, you can really be very, very precise with catheter manipulation. And even though catheter ablation is quite safe and effective, right now it's reserved as a treatment for patients who have failed antiarrhythmics. I certainly hope that some of the experience that we share in our publications will move the field where this can be considered primary or first-line therapy for the outflow tract tachycardia patients. So I'm going to stop here, and I thank you for your attention.
Over to the moderators. Narasimhan can unmute, and you can take over. Narasimhan to unmute.
Right. I'll ask wonderful talk as usual. Sanjay, thank you so much. We'll invite my coaches, Dr. Raja as well as Yadave, to have their comments. We'll have their comments and then invite the questions.
I looked the chat box. No question was asked by by the audience.
Yadave, you will not be able to see. There are questions here. There are several questions here. Would you like to take over those questions first, or would you like to make a quick remark?
Because in the chat box, I am not able to see.
You will not be able to see.
Can you forward it to Sanjay directly, whatever question?
Yes. Dr. Sanjay, you know what? The questions are the same thing what you have been given. So you can go on, putting that up and then discuss something about it.
Okay, sure.
The same thing, or you can extemporarily talk about those questions. Most of the questions are the one what you have said.
There was a question that what is the recurrence rate after ablation?
Right. So in general, the recurrence rate, so the success rate of 85 to 89% that we reported, that is suggests a recurrence rate for us of about 15 to 20% following ablation of these tachycardias. So single procedure efficacy is about 85%.
Do you take other ECG like V3R or V7, V8, V9?
That's a good question, and several people have suggested doing that. We have not used that in any rigorous or scientific way to validate some of our algorithms, but I can see the value of moving the leads around to localize certain spots. Absolutely.
I think Dr. Selvaraj, do you have some questions you can ask?
Well, that was a fantastic talk. Thanks, Dr. Dikshit. So I think there's one question here which they pasted from there, which is there a relevance the understanding the mechanism, does it in some way guide us to ablation therapy?
That's an excellent question. So far, what we know of the outflow tract tachycardias is that because of the mechanism, the site is focal and the activation pattern is centrifugal. And usually at the site of ablation, you expect your catheter timing to be maybe 15 or 20 milliseconds ahead of the tachycardia. But there are certain locations, for example, in the cusp region, you can sometimes have fibers of muscle that extend, where you can have the local activation precede the rest of the QRS by as much as 50 milliseconds or more. So depending on the region where you're targeting these, you may have different cutoff values. One thing to pay attention to, and this is where this entity is somewhat underdiagnosed. So usually outflow tract tachycardias, because of the underlying mechanism, delayed after depolarization mediated triggered activity, that's evanescent. It should not be something that should sustain VT. Usually it can do PVCs or non-sustained VT. So if you have sustained VT, you have to really think about some other explanation. Even though they get binned as outflow tract tachycardias because the echo may look normal, sustained VT is unusual for these areas. So you have to really think about whether there is some structural heart disease that you're missing. Sometimes people can have an intraseptal substrate where you can have re-entry, but an echo may not show it. You may need to think about more advanced imaging. So if it's a sustained VT, explore and make sure there's no fibrosis or something.
Can I have one more question, sir? About any outflow VT may lead to short coupled onset leading to VF or flutter, ventricular flutter. Do you have some cases like that?
So I think this is where we also have to
normal heart, structurally normal heart.
Yeah, so I mean, we have certainly seen that happen in cases of idiopathic VF, and the most common PVCs for those cases, they either tend to be papillary muscle or the outflow tract region. There is some discussion about how Brugada may be a structurally abnormal heart with something localized to the outflow tract region. And even though phase 3 re-entry has been considered as the underlying mechanism for the PVCs, that may not necessarily be true. That being said, if you think about idiopathic VF cases, and I don't have any accumulated data to say that that's how it ought to be. Usually when you think about polymorphic VT being precipitated by a PVC, those PVCs for the classic long QT, they are mediated by EAD, early after depolarization mediated triggered activity, phase 3. And usually in them, the underlying heart rate is slow, right? So R on T phenomenon is usually EAD mediated, and the underlying heart rates tend to be slow. Whereas with outflow tract tachycardia, which is DAD mediated, the underlying heart rates tend to be moving faster. In fact, that's one of the ways to differentiate it. So I'm not sure if you necessarily see idiopathic VT/VF with your classic outflow tract tachycardia because of the DAD mediated triggered activity, which requires a faster heart rate. It's a phase 4 depolarization.
How frequently you use ICE in RVOT or LVOT VT? There was a question. Yeah.
We never do any VT ablation without ICE.
Okay. Any more
In fact, ICE has been the game changer because it helps you very quickly create the shell besides catheter localization. So it's become now to us an essential tool. So all our cases are done with ICE.
Any more questions, sir? Narasimhan, sir, you have any question?
Very wonderful summary of everything. We have seen a little bit of change in morphology when you ablate an exit of aortic cuspal VT from the right side. You have a transient success, but then the patient will come back with a recurrence. That's because you have sealed one exit and there are these multiple exits. But we see this more often characteristically in aortic cuspal VTs. Have you seen this phenomenon?
Yeah, no, absolutely, Narasimhan. I think when we look at our experience, and as I told you, our early experience, we were targeting a lot of these in the RVOT. I think the tachycardia could still have been a cusp PVC. We were just targeting the exit side. But if you don't get to the source, then you can see how they can change the patient. We have seen that happen certainly in the cusp region, but also a lot with the LV summit. Because on the LV summit, you can have all these different exits, and you really have to, and you can't really get to the source most of the time because it's on the epicardium under the coronary vessels. So there you have to be very meticulous in targeting the different exit sites. The PVC will change morphology, and it does require a lot of ablation from various patients to finally close it off.
So thank you, Dr. Narasimhan. Wonderful. It was great. It was the inaugural session, and Dr. Narasimhan, I take pride here. 250 people are actually witnessing this event. I think this is a great success, and it's all Sanjay. Please take credit. We all waited for your talk. This is one of the important talks here because this is one of those VTs which Indian electrophysiology community can actually deal with without much of a hardware, etc. Thank you so very much for being so very kind. You finished. I know we would have gone on forever, but you tried to make your talk very compact. Thank you very much, Dr. Narasimhan.
Thank you, Sanjay. Thank you.
My pleasure. Thank you very much. Congratulations on this.
So we are going quickly to another important talk by one of the experts in the country, a very well accomplished electrophysiologist, Dr. Haigreve Rao, my dear friend. And we have a set of moderators. Ajit Kumar, he is the professor and the head of the department of Sri Chitra electrophysiology department. We have got one distinguished Dr. P.S. Mohan Murugan, who is the accomplished interventional cardiologist of Chennai City, and of course Dr. K. Tamil Selvan, who are going to be moderating. I request Dr. Ajit to take over, introduce our distinguished speaker today, the second talk, Dr. Haigreve Rao. Over to Dr. Ajit.
Good evening, everybody. At the outset, I should wish all of you a very happy Onam, and with that, I'll begin. Of course, I think all of you are quite familiar with Dr. Haigreve Rao. He is the director and the head of electrophysiology at the KIMS group of hospitals in Hyderabad. I've been specifically and particularly impressed by his interest in research, especially in sudden cardiac death and areas related to VT. He's, of course, the editors of a lot of other cardiology journals as well. But he has a very keen interest in research, and that's probably what makes him different. Over to you, Dr. Haigreve. This VT storm is a very interesting problem that all of us will meet, not as electrophysiologists, but also as cardiologists. So over to you, Dr. Haigreve.
Thank you, sir, for a very kind introduction. And thank you, Ullas, for this opportunity to talk in this forum. I've been asked to talk about a case on VT storm. Now, we had a series of cases of VT storm. There is one which actually made us learn a lot of lessons, and the lessons which I would like to share with everyone, and that is what I'm going to present. Now, a VT storm, basically by definition, is 3 or more episodes of VT or VF in 24 hours requiring intervention of defibrillator. Incidence is 10 to 28%. The important thing is a twofold high risk, a risk of all-cause mortality. Now, for those of you who are doing interventions, I would like to say that you see stent thrombosis, but when you see a VT storm, stent thrombosis would look like an angel. Now, this is a patient, a 59-year-old gentleman, hypertensive, old anterior MI, very remote anterior MI, and he also had a documented sinus node dysfunction, which he was managing. He had one episode of syncope. The echo showed a regional wall motion abnormality in LAD territory, moderate LV dysfunction 35%, and angiogram was done at old proximal LAD lesion, for which he was getting medical management and nothing impressive otherwise. Now, obviously, we are thinking of a sudden cardiac death in a patient with old anterior MI and syncope. And so we did a cardiac MRI for him. What we saw in a cardiac MRI is a large transmural, non-viable LAD territory, and which was expected for the old anterior MI and moderate LV dysfunction. But interestingly, we also found a significant LV clot at the apex going upwards to transiting to the septum. Now we'll talk about this issue, the LV clot issue a little while later. But what was clear was this patient was a candidate for sudden cardiac death, and we were thinking of evaluating him further. At this point, in the ICU itself, he had a documented syncopal VT, so that completely clinched the diagnosis. Now there's nothing to do. Because he had a sinus node dysfunction, we implanted a dual chamber ICD, and he discharged with standard medications. Now, 20 days later, patient had 2 appropriate shocks. Medical management, we stepped up his metoprolol, amiodarone. Lower rate was programmed to 50. We wanted as low as possible. Rhythm was atrial paced. We thought, we had probably got over the crisis, and he would continue with this kind of thing. But actually what happened was he had 3 appropriate shocks in 12-hour duration a month later. Hemodynamically stable, and he was brought from a remote place to Hyderabad because he was not living close by, and there was no medical facility there. They were bringing him in a vehicle, and he brought here, and despite the different antiarrhythmic drugs we gave him, he continued to have ICD shocks. And while coming, when we interrogated him, we realized that in the journey, he had had 13 episodes of requiring intervention. So obviously, we are dealing with a storm. He was electively intubated, amiodarone, and we maximally tolerated metoprolol was given. Atrial pacing was increased. There was a thought that we increase the atrial pacing, it suppresses the VPCs. So we tried to increase the, fortunately, he had dual chamber ICD, so atrial pacing increased suppressivity, but he continued to have VT unrelentingly. Now the problem was, the challenge was this patient we thought of doing an ablation. But the problem was this patient, as I told you, had LV clot. You can see we repeated the echo, an organized LV clot still there, which was the same thing which was previously seen on the MRI. Now the problem is, if you do an endocatheter manipulation, the concern is it can potentially dislodge this thrombus and result in a cardioembolic stroke. So you are in a catch-22 situation where we cannot do an ablation easily. So this patient was referred to a oncosurgeon who does the cervical symplectomy at our center. He used a quite fancy equipment, used a robotic to cut off the sympathetic ganglia. So what we do is a surgical procedure done for a VT storm. It is well described in many centers in the world and well documented in literature. It is a surgical procedure where there is excision of the distal half of the stellate ganglion and T1 to T4 sympathetic chain. And that's exactly what was done on the theater. And they sent it for a frozen section to prove that they had done the job. And what actually happens is, as you can see, the thoracic ganglia, the thoracic spinal cord and the sympathetic ganglia, they have inputs, sympathetic inputs to the heart. And these fuel the VTs and the VT storm. So what actually we do by doing the sympathetic ganglionectomy is to cause a very high intensive beta blockade, because you're cutting off the sympathetic supply to the heart, and then we try to achieve a relief from VT storm. So we did thought that we had done the job. 3 days after sympathectomy, he developed recurrent appropriate shocks for VT, continued to have shocks. Now this was a nightmarish situation. Look at the VTs, and you got 26 episodes of VT. You can see a lot of episodes had ATP converted, and shocks were there, but predominantly in the VF range, very fast ventricular tachycardia resulting in a lot of shocks. So this was a very difficult situation. Then we realized the patient was in mechanical ventilation with paralysis, completely knocked down. There is no sympathetic inputs because you had already done a sympathectomy. We'll try to look for if there are any reversible causes, but all the biochemical parameters were normal. ICD was shut off now, and only external shocks were given because it just drained the battery. Patient continued to have recurrent VT despite all medications. Repeated electrical cardioversions were performed, and something like 70. You had the fellow keeping on shocking and doing these kind of things. So this was a situation at which we decided that we were pushed to the wall. We had a clot in the LV. We had already done all that we could, and this was a patient who continued to have VT. We need to do something. So then we decided that risk or no risk, we had to do a 3D mapping guided ablation was planned for this patient with the risk of a stroke and all this explained to the patient. Now, what we saw when we took him to the lab, now I'm going to show you the pictures. I'm going to show you the next couple of things are all in the lab, EP lab. Made it at a speed that is looks like an ECG for easy understanding. So what we saw was a VT, a sustained monomorphic VT, but the problem was these VTs were hemodynamically unstable. The moment the VT came, we had to shock it to sinus rhythm. And more importantly, not only the VT was unstable, but there are multiple morphologies of VT. As you can see here, the 2,3-AVF is positive, and there you can see somewhere else that it is negative. So these kind of multiple morphologies of VT, and these are broad, notched, these are narrow. So not only there are multiple morphologies, not only they are hemodynamically unstable, but they are interchanging. This was changing to this was changing to this. So this made it mapping almost impossible. So these unstable VTs, multiple morphologies. So then we decided that this patient had to be substrate-based mapping. So this patient was completely converted to sinus rhythm with a anesthetist putting on the maximum propofol and keeping him paralyzed, and then made him for a sinus rhythm for the time of mapping. What we did was then we started doing a voltage mapping. Now, as we can see, this is a three-dimensional map in the sinus rhythm of this patient. What you can see, the red area is all the scarred, the infarcted area, and the pink area is the health area, and the colored area is in between. And we can see the voltage between 0.5 to 1.5. That means anything less than 0.5 was a scar. So you can see that a lot of dense scar, extensive mapping. Initially, about 538 points were mapped all over, and then what you can see is the different views showing the large extent of the scars, the scar in the left ventricle. The whole thing is a map of the left ventricle. Now, what we found was the potentials. Now, the important thing was mapping in the area between the scar and the normal area. This is the colored area you can see. These are the borderline areas. So when we mapped in these areas, we found different kinds of potentials. One was the isolated potentials. You can see the V1 is a ECG. The corresponding to it is the electrogram, but you see the actual electrogram is very far away from the electrogram. So these are the late potentials, the isolated late potentials. We try to ablate them, and you can see that the amplitude of the late potential as you ablate comes down completely, it goes away. So we try to map for these late potentials. And the next, the potentials was the continuous electrical activity like this. You can see that the entire QRS complex is represented, but not by a precise electrogram, but by a continuous low voltage electrical activity like this. So these are the continuous electrical activity. We targeted this. And if you look at all the electrograms we targeted, one was the late potentials, one was the fragmented potentials, one was the double potentials. That a single EC electrogram is represented by two electrograms and not one, showing that the area of block in between them. And these are the fragmented late potentials. So all these things were targeted for ablation on these points. And you can see that we marked this by color. Each of the electrograms that I showed was marked by a specific color. Blue represent this, for example, yellow representing a late potential and blue representing a CEA, and so on and so forth. So what represents these red dots and brown dots are all the abnormal areas were targeted and were ablated systematically in all these areas. So you can notice that most of these abnormal potentials are in the border zone, not in the scar, not in the healthy zone, but in the border zone with a colored activity that is in between the scar and the normal myocardium. This is where most of the abnormal electrograms were there. So patiently, carefully, all these electrograms were as many as could be mapped, as many as we could see, they were all burnt. At the end of the ablation, there was no spontaneous VT. Program stimulation, this was very gratifying because this patient had so many VTs in the last few days. Programmed electrical stimulation from RV and LV with single and double electrostimuli did not induce VT. We did not do any further heroic methods to induce. We were quite happy with what was achieved. Now, what is important is that day two, he was extubated. There was no neurological deficit. And this was most gratifying thing, more than as important as the VT ablation. And no further VT episodes during hospital stay. Patient was discharged after 4 days with amiodarone and metoprolol VT. And no evidence of VT in the last 5 years on ICD interrogation. Now, there are two messages and two lessons we learned in this. One was a protocol-driven strategy for VT storm, and the old LV clot is not a contraindication for endocardial ablation. The first one was a protocol-driven strategy. Whenever it is done, we actually had a lot of cases of this. We compiled about 12 cases and published them to show a protocol. What we actually saw that we should have a protocol in the institution. That is exactly what we were trying to learn and trying to share. is that patients with VT storm either have a recurrent VT or an appropriate ICD shocks. The first thing is to work up for reversible causes, including ischemia. In fact, 2 of our patients who had actually unrevascularized areas, which we underwent stenting or a graft, and patients had thyrotoxicosis. And important point I'd like to see is that mechanical ventilation. All patients had almost all of them had mechanical ventilation. So sedation and mechanical ventilation is extremely important in VT storm, we realized. And eventually, all of them should undergo a mapping and ablation. When it is not possible, either sympathectomy can be an adjuvant to it, or can be an isolated, you can be either or. And 85.6% survive to discharge, and most of them are alive. 14 are alive. All of them are alive at more than 3 years with VT recurrence in 2, but they're medically managed. The second thing is LV thrombus. We were very scared of LV thrombus causing dislodgement and strokes, but then we were pushed to a corner. We would not have done this case otherwise. Other cases we had never done a ablation with a thrombus before, but with this, where we were pushed to the corner, and we did. And we were trying to look around the world if anybody had a large series with that. And we pulled out, and Dr. Kalyan was kind enough to pull out his archives. And we published our cases along with his. And where we looked up and showed that in a patient with LV thrombus also, with old organized LV thrombus, we can do a VT ablation. And the ablation results were similar to those without thrombus in historical controls. So it is shown that epi and endocardial are safe. And subsequently, actually, we had 2 other cases. We had it old organized thrombus with the VT storm. We simply went ahead with ablation without.
I'm extremely sorry to interrupt you, sir. 2 minutes.
I'm coming to the last.
Sorry,
slide.
sir. 2 minutes of screen time.
Thank you very much.
Most welcome, sir.
So in end, I would like to say that VT storm is a extremely scary situation that a cardiologist, electrophysiologist faces in the lab. And these are the things that a protocol-driven strategy is extremely important, because we realize as we go across the protocol, there are a lot of things that need not go all the way. Sedation and mechanical ventilation is paramount, maximizing beta blocker, and radiofrequency ablation with the 3D mapping is almost always required. And it has really improved the success rates and the results of VT storm. Thank you very much once again.
Thank you, Dr. Haigreve, and over to the moderators.
Thank you, Haigreve, for that excellent case, fantastic case presentation. In fact, in all of our series, we have not had any patient with an LV clot sitting down. I will just make one point and then give it to the other moderators. See, in that MRI which you had shown, it did not look like an organized thrombus. It almost looked like a fresh thrombus. I was a little worried about that, one. And 2 is that, as somebody pointed out, is that you can use carotid filters. Of course, we have not used that while doing the ablation. And the other point that perhaps is an important point for everybody to take note is that we have to note the triggers down. What we found is that in majority of our cases, they had hypokalemia as a major trigger. So if you correct hypokalemia and hypomagnesemia, the level of potassium should be above 4 and magnesium should be above 2. That is a very important thing which can be taken care of by anybody. Over to the other moderators.
It's a very interesting case, actually. The patient was saved by the timely ablation, and it's very nice to hear from Haigreve Rao. Thank you very much for saving that patient.
Thank you, sir.
Dr. Tamil Selvan, you have a comment to make? Dr. Tamil Selvan, you'll have to unmute yourself, please.
So I would like to know the difference, if at all, by using, you would have used propranolol in the place of metoprolol. What is our experience of using propranolol in VT storm?
No, in general, in all patients with ventricular tachycardia, our experience and data has always been used to use a selective beta blocker. In fact, metoprolol is the most well-tested and the most efficacious beta blocker that we have used in this set of patients. In the sense, what I meant to say is in ischemic cardiomyopathy, the kind of patient that I'm presenting was ischemic cardiomyopathy. VT storms can occur due to different substrates. It can occur occur, long QE can occur in Brugada and so on and so forth. But in ischemic cardiomyopathy and dilated cardiomyopathy, which we see most often, I think the best drugs, beta blockers, would be metoprolol.
But the patient had ejection fraction around 35, isn't it, sir? In that case, it will be useful if you target the beta 2 receptors also, because the beta 1 receptors will be down regulated.
See, the issue here is the issue of heart failure is, I think, a little different from VT. When you have a VT which is predominantly fueled by beta 1 receptors, I think selective beta blockers are certainly very useful, and they cause so much of bradycardia, which is also very useful in the management of VT storm.
So I agree. This was a great case, and congratulations on a really nice outcome for such a challenging scenario. That's all credit to your skill set. Just a couple of points to make, since you asked the question about eyes for my talk. So if you were using eyes in this case, the benefit would have been you could have very quickly created the LV shell while also monitoring your catheter, because you can see live how close you're getting to the thrombus. We typically don't hesitate to go into the LV if it's a laminated thrombus. I don't know if you could tell that or not, but that is something that is to be expected in a person with a healed myocardial infarct and a dyskinetic segment. And then the last point, more of a question: do you really think intra-aortic balloon pump helps? Because usually for these scenarios, we generally use either an Impella or put them on an ECMO during the procedure. But I'm not sure if intra-aortic balloon pump necessarily gives you much.
Another question I would like to ask is the recent attempt of using transcutaneous magnetic stimulation to control these kind of scenarios. What is your take on that?
I have no experience. I think Dr. Sanjay would add to that. I have no experience with the magnetic thing in VT storm.
We have never used it.
What about this transjugular sympathetic ganglionectomy? Is it procedure to be adapted before going for a surgical one? Have you got any experience, sir?
Do you mean to say
transjugular cervical thrombectomy?
Yeah. See, I think in the last few years in patients with VT storms, what you learned is that even if you do a sympathectomy, the efficacy is not 100% as you have seen in this case. So we personally, when we want to do it, we go in for a bilateral complete surgical excision from distal to T2, T4, a perfect excision to get any kind of benefit.
Thank you.
I think that's an important question that he has, Dr. Musalvan has raised. That is it useful to do percutaneous one? It is a very simple procedure. We do it as the first part of it, especially if you do not have a surgical facility.
You said in your last talk, I heard that in the IHRS meeting when you said that. Yes, please enumerate it.
Especially if you do not have the surgeon at hand, it's very useful to do a left stellate ganglion block using, but you should have an echo and ensure that you are actually doing a perfect injection. Even if it goes haywire, still it doesn't really matter. There's not much of complications to do it, but it'll just control. So everything added together, this is an incremental controlling factor. So I think it'll be useful if you do that.
So thank you, Hygrev. Wonderful talk. It's inspiring. You took such a great challenge in presence of a LV thrombus is what you said. Sometimes we'll have to be really pulling up our sleeves. Ladies and gentlemen, I have this privilege of introducing and welcoming one of the sharpest minds and the young star of electrophysiology in the country, Dr. Daljit Kaur Saggu, who has been the disciple of Dr. Narasimhan, and she's going to be speaking on sarcoid myocarditis, and the moderation would be by her own colleagues, Sharda and Debabrata. Sharda, she came to Chennai. Debabrata is in Kolkata, and ably accompanied by Dr. G. Selvarani, who I always admire, with her work in interventional cardiology and her interaction with ECG. She had been one of our so-called well-wishers of the program. So Selvarani welcoming you, Daljit welcoming you, and all the moderators. And over to the moderators, Sharada.
Yeah, thanks, Dr. Ullas. Really pleasure to welcome Daljit, the bright youngster, as already described by Dr. Ullas. What to describe about her, but right now she's working, being trained as a fellow with Dr. Narasimhan in Care Hospital. She is continuing to work with the team, now moved to AIG Hospital in Hyderabad. Also co-supervising the EP fellowship program there. Very bright youngster and authored many papers, very research oriented and academic. So let's take on the case. Daljit, over to you.
Yeah, ma'am. Can you hear me? My screen is seen. Thank you for the kind introduction, ma'am, and Ullas sir, and thank you for having me here. Can you see my screen?
Not yet.
Am
No, people will help you, Daljit. Hang on. So, somebody to coordinate with Daljit to get the screen on.
Good evening, Daljit ma'am.
Yeah.
Ma'am, can you please share your screen with the audio on?
There's a green button down which says share screen.
Yes, ma'am. Please share your screen with the computer audio on.
Perfect.
It's on.
Perfect.
Now see?
Yeah,
yes,
we're able to see well.
Able to see that. Can you please go to the full screen?
And Daljit, you are the brightest today.
Thank you very much, sir. And thank you, Hygrid sir, because you have covered a lot of terminologies I'll be using during my presentation. So I'll be presenting another case of right ventricular outflow tract tachycardia. This case presented a young patient with a normal echo in 2016, presented with the VT, which is looking like a right ventricular outflow tract tachycardia. This LVBB with the 2-3 AVF positive and 1 AVLQS suggestive of right ventricular outflow tract tachycardia, which was reverted with IV beta block. And then someone took him for EP study, and because a lot of ET morphologies were induced, no ablation was performed. And good thing was MRI was done in this patient. So before going to that, I would like to highlight one thing. This is the sinus rhythm ECG of this patient. And I'd like to highlight this sinus rhythm ECG is not a normal ECG. You can see there is a right bundle branch block. There's a little low amplitude QRS in the limb leads, lead 3, lead AVF. So we have already published from a center one case series mentioning that if you have outflow tract tachycardia and the baseline ECG, if you have some kind of bundle branch block, some kind of fractionation of the QRS, low amplitude QRS, you should think of some another thing going on in this patient. So MRI was done in this patient, and you can see that in the MRI, this patient had a scar, which was a basal septal scar, which was more towards the right ventricular outflow tract plus intramural, extending towards the basal septum into the epicardium with the deep intramural scar in the epicardium. So I don't know why the diagnosis of viral myocarditis was made in this patient. Anyways, because of the viral myocarditis made, no further investigation was done in this case, and the angiogram was done which showed normal coronaries and single chamber ICD implanted. He was put on some drugs. He was doing well for next 2.5 years, but after 2.5 years, he went into VT storm, and which was not responsive to multiple antiarrhythmic drugs. Because it was not responding to antiarrhythmic drugs, in April 2019, surgical videoscopy guided bilateral sympathectomy was done. I think all these terminologies has already been explained and spoken by Dr. Hygrid sir. So this is a nice ECG I wanted to put. So after a year, that is in May 2019, you can see the disease has progressed in this case. And you can see the QRS has become more fractionated in lead V1, lead V3. So there is something going on. So there is a progressive disease in this patient, and I don't know, this was not followed up. So anyways, in Jan 2020, again patient went into VT storm, initially attempt to manage with the multiple antiarrhythmic drugs. March 2020, it was not manageable with antiarrhythmic drug. When he came, he had more than 200 episodes of shock when he reached to us, and LRL was kept at 90 per minute to suppress the beat. It's a single chamber ICD. And once he reached, we tried because he was in Strom. In the emergency, we gave him general anesthesia. We started lignocaine amiodarone infusion so that we thought that we can get rid of the Strom. We can cool him off and stabilize the patient. And by this time, the EF had dropped to 40%. So with this under general anesthesia, with these drugs, we did the PET CT scan for this patient, which showed that a segmental uptake in the LV along with the baseline uptake, but the segmental uptake was around 7.2 SUV max. He had lymph node uptake. And we were lucky node at right supraclavicular biopsy, which showed a non-cascading granuloma. So because he had MON2 and quantiferin positive, we didn't want to give only steroids. Other parameters for TB were negative. We didn't want to give only steroids. So anti-tubercular therapy along with steroid was started and along with the antiarrhythmic drugs. Luckily, he improved with this. We could extubate, shift him to the room, and after a few days, we discharged the patient on these drugs. He was doing well for a few days, but after 2 months, he again came with the increased episodes of the VT in next 2 months. And you can see he had more than 200 episodes of the VT with lot of shocks. So now we thought again PET CT was done, and we saw that the inflammation has come down. We thought that inflammation has been settled, so we took the patient in the lab for the ablation. But when we took him for the ablation, you can see he was just going into the multiple morphology of the VTs, which were hemodynamically unstable, and all were different morphologies. You can see it's an RS. This is right bundle, right axis, but RS and V1. It was hemodynamically stable. It didn't allow us to do any activation mapping. This is another morphology with the QR in lead V1. This is another morphology with V1 having a monophasic R. So we had to give multiple shocks to him because we were not able to, and patient was not staying in sinus for long. So I have just highlighted this 10 morphologies of the VT, which were all with the different morphology and different cycle length. Although he had almost kind of 15 morphologies, but these were the 10 morphologies which were sustained and which was requiring termination. And to highlight that this second morphology, which is right bundle with the QS in one AVL, was much more predominant, and one of the left bundle outflow tract ventricular, right ventricular outflow tract ventricular VT was also predominant. So we could not do any activation mapping because of this hemodynamic instability. We mapped epicardium, RV, LV, and the cusp. There were no low voltage signals except in epicardium, LV, basal anterior, and the anterolateral wall, but there were no abnormal signals. We mapped even RV and the LV, both unipolar, bipolar voltages were normal, except for in the RV septum, we had some low voltage signal, but there were no abnormal kind of signals which we should do substrate ablation like Dr. Hygrieve showed us. So thus we thought that the previous two morphology of the VT we will pace map because we had taken the patient for ablation. I'm just showing only the epicardial map here. There's a anterior basal scar, and you can see I've just highlighted one of the reason, although it's a low voltage, but there is no abnormal signal here. So we could not do any substrate modification in this patient. So only thing, because we had taken an epicardial axis, the area we could write that right bundle, right axis kind VT, we got a good pace map. That area was a phrenic capture. That's why you can see it's a long Cook balloon we have placed. And just to get rid of the phrenic, because that area had a phrenic capture. So to get rid of the phrenic, we have, and just to make it sure that it's away from the blood vessels, we had placed the balloon and we have lifted the phrenic nerve so that we can perform ablation without any injury to the phrenic. So anyways, this ablation was performed for some 7-8 hours, and after that we shifted him out. We thought that at least some episodes will come down, and because we realized although PET did not show much inflammation next time, but because of the so many morphologies of the VT induced in the lab, we tapered off the steroid and we changed from steroid along with the ATT to mycophenolate, and we continued multiple antiarrhythmic, including beta blocker, sotalol, mexiletine. I just want to highlight in the beta blocker, we tried in this patient bisoprolol, we tried Inderal ATTID also. So multiple different beta blockers were tried in this patient. He was stable for 2 months. In between, he had lot of episodes, maximum reverting with the ATP. But again, after 2 months, he came with 2 to 3 shocks every another day. So we thought, let's again, because we have given some drugs to the patient, we took him in July again for the ablation. So this time we had clinical VT1. You can see it's a V1 QR morphology. That is looks like some septal VT. Next, this is which we thought we have ablated successfully. This is right bundle with QS and 1 AVL at a slower cycle length. It's a slower VT. This time it was hemodynamically stable, was still coming. So these were the 2 clinical VT ECGs we had. So when we took the same 2 morphology PVCs are there. Because of sympathetic ablation, sympathetictomy was done for this patient. His sinus rate was very slow. Usually supposed to be in junctional with the VT or PVCs. That's why initially we started A pacing so that we can suppress the VTs and we can map the VTs. So these were the 2 predominant morphologies seen. And because we had this basal VT like with 1 AVL negative with RBBB, we had placed the DECA in the interventricular vein, but you can see it's not early, not a very convincing signal there. So within the LV near the septum endocardial, we got a very good early signal. You can see it's an early signal, nice 40 millisecond early for that QRBBVT with the PVC2. And it's a nice site. We started ablation. So as soon as we started ablation, you can see in the halter also, nicely it suppressed the PVCs. So, but when we were doing the ablation and trying to consolidate the lesion, you can see it's gone into junctional and we had stopped pacing for some time, it had gone into junctional. So while we were doing this ablation, he changed that this VT1 is induced, that right bundle, and the QS and 1 AVL VT is again induced, which was hemodynamically stable this time. So we thought we are lucky it's an hemodynamically stable VT. We consolidated the lesion for VT2, and then we started mapping for the VT1. But while doing that, you can see this has changed from VT1 to VT3. So VT3 is also right bundle. It's a different cycle length, but it's a pattern break. V1 positive, V2 negative, again V3 positive. So because both these VTs are looking like epicardial VT, before going to epicardial, last time we had done epicardial ablation, we thought we can attempt the wire mapping. So through the CS, what we had done, we have placed a wire in one of the PLV, and we thought let's try pace mapping. So although we were not able to, you can see I'm not able to see any signal. So no signals are seen at this site, but luckily we were able to capture at this site. But it's not a good pace map. The pace map was not good. So at this site, PLV proximally, distally, and one more lateral branch we attempted pace map, but these signals were not good. We didn't get pace. So ultimately we took epicardial access and started mapping. So while doing the viral mapping, you can see again VT3 is induced, which is sustained and hemodynamically stable. And we started mapping this VT3. And you can see we got a very good signal. This is one of the kind which Dr. Haigreve showed. This is a low amplitude, high frequency signal. And this is another signal with the gap. And you can see the signal to the onset of QRS. The distance is 40 millisecond. We started pacing, and the distance from the stem to the onset of QRS, you can see the tiny signal has captured and not the main signal. And this was 50 millisecond. So this is a concealed entrainment, nice concealed entrainment, but PPI minus T cell is long, and plus stem to QRS is longer than the EGM to QRS, which shows that this is not a main isthmus where we should ablate. So we knew that we have to move nearby the area. We are somewhere nearby. So we got ultimately a better signal. You can see this is a higher frequency signal, which is 26 millisecond earlier. And we got a good PPI minus TCL. But you can see stim to EGM is almost 0. So it's an exit site, but this is the best we could get. And it's a concealed entrainment. So ablation was performed at this site. So you can see when we started ablation, at this site, the VT3 terminated and slowed down and terminated, and then during RFA, it changed to VT1 at a different cycle length. So we thought that was a successful site of ablation. We consolidated the lesion at that site, and after consolidating the lesion at that site, we started mapping VT1 again. This is a site of ablation for VT3 with the pattern break, and now we have started mapping the VT1 again. Now you can see this is another site. This site, although it's an early signal, 30 millisecond early, but I would like to emphasize here, the initial part of the signal is very low frequency. So it's not, I'm not sure whether it's very convincing, but this is the earliest site we got. We thought, let's do entrainment. We started entraining. You can see that it's a good entrainment. Your post-pacing PPM minus T cell was less than 30 millisecond, and it's a concealed entrainment. The only thing is it's an exit site, but this is the best we could get, and we started ablation at this site. And you can see when we started ablation, the VT has slowed down. Even in the halter, you can notice that the VT has slowed down, but it took long time for termination. So although it terminated, we consolidated the lesion. It was coming again and again. Now it is again reinduced at a slower rate, sometimes sustained, sometimes non-sustained. We realized that we are near the exit site. So even endocardial, we didn't get a good signal. So that's why we thought, let's do endo-epi mapping at this for this VT. So the upper two signals, MAP distal and MAP proximal, are the epicardial signal from the epicardial catheter, and the third one is the signal from the endocardial catheter at the diagonally opposite side.
Sorry to interrupt you, ma'am. I'm extremely sorry to interrupt you, ma'am. 2 minutes of the screen time left.
Yeah, I'll stop in 2 minutes. It will be done in 2 minutes. Yeah. So ablation was performed. You can see this is a bipolar ablation was performed at this site. This is an RA and the LAO view. Bipolar ablation. I know this is the measurement done. It's a 14 millimeter. I know it's not a very precise measurement, but in different angle, the measurement was from 14 to 23 millimeter. We gave ablation at this site. And I just have put one 3D map to show this is a superior view so that I can show the catheters. This is the endocardial, which was the active catheter from which ablation was performed. And this is an epicardial catheter behaved like a patch, and the bipolar ablation performed. You can show that VT has been slowed down and after that terminated. So after a long time, first time we could see a sustained sinus rhythm of this patient. So post ablation, because the device was already ERA, we again gave a donated dual chamber ICD so that we can pace atria, and he's doing well till now. It's been 2 months. So my only key message is all the right ventricular outflow tachycardias may not be idiopathic, and we should look for markers of any underlying inflammation or scar during the sinus rhythm when it has been terminated. Cardiac MRI, especially if T2 mapping is not done, if edema is not seen, it may not show the inflammation. So you should not underrate the role of PET CT scan, because the early treatment, early diagnosis of inflammation, we can halt the progress of the disease. Steroid resistance is not uncommon in sarcoid. So always think, if the patient is not responding, you should consider steroid sparing regime. We have already published our data on that. And ongoing inflammation is always under recognized. So we have already published data saying that if you do ablation during an ongoing inflammation, the outcome is not good. So you should always treat the patient first. Once the inflammation is silenced and still VTs are there, then you should take the patient for catheter ablation. Thank you.
Great job and bewildering number of VTs over there. It's an extremely challenging case, and I mean the time given also is not commensurate with the complexity of the case. While we understand, I'm just wondering why there was so much of sustained arrhythmias of different kind going on. You think inflammation was not? Was there any inflammatory marker which was showing that it wasn't responding very well or anything, Dr. Kalchi?
Ma'am, we have already done in our data. We used to initially do all the inflammatory markers like HSCRP, or we used to do ESR, but we have realized that that doesn't correlate with the degree of inflammation. So that we have already seen in the data. So frankly speaking, we didn't repeat the inflammatory markers, but the fact that the pleomorphism, we had around 15 morphologies when we took the patient on table. The fact itself says that there is some underlying inflammation which we should take care of.
But
so that's why
you repeated a PET CT, as I understand.
Yes, and inflammation had come down. That's the reason we took him on the table rather. That's the reason we thought inflammation has gone, but when we took the patient on table, there were again a zoo of VT induced. So I think that is another marker of when you have so many VT morphologies coming from all different, even from RV, we had 3 different morphologies of VT, from the LV, multiple morphologies of VT. That can be a marker of inflammation, because 2 months of mycophenolate, when we took him again, the number of VTs induced were 5. So from some 50 morphology, it came down. So I think there was some inflammation which has been treated over the 2 months.
Somebody wanted you to elaborate what are the ECG markers of cardiac sarcoid.
So sinus ECG markers, you can get bundle branch blocks, you can get fascicular blocks, you can get low voltage complexes, you can get fractionation of the QRS like I showed in this patient, especially in the V1 and V3 seen nicely. So I think these are the markers of the inflammation.
And somebody also wanted to know why, no, Dr. Yarve wanted to know why PR is short and did you use infliximab?
We didn't use infliximab in this patient. Ultimately, we use adalimumab in this patient, ma'am. And yes, the PR is short, but HV was normal. Because of the short time, I have not put the his. So baseline HV was normal. AH was very short in this patient.
Right. Any other comments from the moderators? Devabrata
and moreover, few places where the PR looks very short, I think it's a junctional rhythm also was coming because sinus was very slow. So the few places it was the junctional acceleration, and I think it was dissociation. It was looking like PR conduction, no the sinus conduction, but because junctional was faster than the sinus. Yes, Dev.
Hi. Very elegant
Thank
presentation
you,
as usual. So just one or two doubts. When did you do the PET, repeat PET, before the first ablation or the second ablation?
Second.
Before the first ablation was done. First was baseline when he came to us,
right,
when we sent him.
I know.
Before the first ablation, repeat PET was done. There was no uptake.
Okay, if I have got your case correctly, that then you said in the first ablation you took endoepicardial both approach, and you did not find much of substrate.
No, there was except for there was a scar, but there were no abnormal signals to ablate. There was no lava kind of signal. There were no late potentials. There were no fractionated low signal, long fractionated signal. We had scar in epicardium. We had scar on the RV side of the septum.
Okay. So means from that one scar, how can you explain so many morphology of VT at Sharda Madam?
That's why I'm saying it's not scar related. That's why I'm saying despite not having any abnormal signal, it's inflammation related. That's why I'm saying if it was scar related, we could have substrate modification and number of morphologies of VT could have come down. So there was no abnormal signals for us to do any modification.
I got your point. But in the second ablation, you did entrainment mapping. That means you want to say
those are very lucky. I think maybe it was you had given biological to the patient. When we took second time, we were lucky because all VTs we were able to do activation mapping.
Yes.
And entrainment we were able to do.
Yes, the entrainment, as you said, means in the second ablation, most of your VTs were re-entrant, as you want to say.
The ones it would have come, yes, because I have already shown we were able to entrain all the VTs. So I think all these were maybe scar related VTs.
But some of the VTs during ablation, you tried to point out early signal. In a re-entrant VT, is there any signal?
Because we didn't get that sort. So, yeah, absolutely. Your point is well taken. So both the sites, especially the bipolar where we have ablated, that's the reason we have done bipolar, because if it's an intramural VT, you will not get mid-diastolic signals, right? You will from endocardial or epicardial, you will get only early. So you're ablating only exit. That's the reason there is a these are the intramural.
But at that site, you had a concealed entrainment also.
Yes, so exit site.
Excuse me, you'll have to take one comment and a question from Dr. Selvarani, please. I think in the interest of the time.
Thank you, sir. Thank you, Ullas, sir, and co-chairs, Madam Sarah, Madam. And it was a very lucid presentation, and some of the patients can present with septal VTs. We have to make them undergo cardiac MRI and the inflammatory markers. And we should not forget the other differential diagnosis like SLE and chronic granulomatous hepatitis, all those things. And it is said that if you evaluate RVOT, the arrhythmogenic RV, some of the patients, 15 to the tune of 15%, they turned out to be granulomatous, that is sarcoid myocarditis. Yes. And how many people they present with heart failure following sarcoid, according to your experience?
In our data, I think Dr. Narasimhan will be able to answer that better. How percentage I really don't remember, but we do have some 10-15% of the patient who come with the heart failure. They may not come with the VT. Few come with the heart blocks also. Few comes with the VT, and then later on they come with the heart failure. If Dr. Narasimhan is there, actually a particular percentage I don't remember. But we do get patients with.
Yeah, sorry, Dr. Daljit. While Dr. Narasimhan takes that question, somebody had asked verbally, I think at that time, how do you define a pleomorphic VT? What are the characters?
So in the single strip, if you see more than one morphology of monomorphic VT, at least more than one, two or three morphology of monomorphic VT, the ECG I have put in my quiz is called pleomorphic VT. Whereas in polymorphic VT, your axis is consistently changing. It's beat to beat, it's changing. Whereas in pleomorphic VT, you have more than one morphology of monomorphic VT. So you'll have 3-4 beats of one morphology, then change to 3-4 beats of another morphology.
At least 6 consecutive beats was what originally it was defined. Anything else?
So, you know what, Sharda, you know what, we will wait for Dr. Narasimhan. Can you quickly come on to that? Because it was an important question raised by Selvarani. Heart failure and sarcoidosis. If you can quickly come up, we can.
Dr. Selvarani, I think this is a very pertinent question. If you take patients where we do an ablation without realizing it's sarcoid, a percentage of them, the ablation will address the VT, cosmetically the VT will go away. But the underlying inflammation progresses to the extent they go on to a transplant list sooner or later. But the problem is in some people it's a self-limited disease and in some people it progresses. So that is the reason why it is extremely important to make the underlying disease diagnosis before progressing. Our thing is we are just publishing next JAC issue that is about if you have patients who have residual inflammation, intense inflammation, but severe heart failure, even PAH, severe MR, requiring almost like a transplant, but their basal uptake is very good. They do very well without a transplant. You intensively treat them. We have had patients referred for transplant evaluation who have improved very well. On the other hand, the uptake is poor. PET uptake is poor. MRI shows a lot of scar. They don't do well. There's no scope for immunosuppression. They need to go for transplant.
So, Dr. Narasimhan, thank you very, very much. You know what? You are the experts. You know, the program was designed in such a way that the best of the minds in sarcoidosis, you and your team members, Sharda, Debaprita, and Daljit, were the best minds to speak about this sarcoid issue. And Selvarani also contributed so much in making us to understand from the best of the minds. And let me tell you here that Dr. Yash Lokandawal's comments, I think it is the best, the compliments to your team. Dr. Yash says to go behind such kind of a sarcoid, I can read up the message from him that it requires a team which has experience, the expertise, and the perseverance. And all of you, the speaker, the moderators, and the guide, Dr. Narasimhan. Actually, this is the compliment from my Guru Yash and from the entire CSI family. Thank you very, very much. It was a great session indeed. Thank you very, very much. And now we proceed to one of my closest dear friend, Ashish Nabar, who is actually going to be organizing the same platform, but in a very, very big way, the IHRS conference. And he's going to be talking on maxillary related issues. And I have this privilege of handing over this session to three important members of the CSI. And those are the electrophysiologist, Dr. T.R. Muralidharan, and aspiring electrophysiologist and almost made name in Chennai city at least as an electrophysiologist, Dr. Ilayaraja, and one of the senior members of the CSI who has a great interest in interventional cardiology, in pacemakers and devices, including the therapies for the HOCM, etc., Dr. Satyamurthy. Dr. Satyamurthy to take over the session and introduce Dr. Ashish Nabar, and you will be you will be ably assisted by Murali and Ilayaraja. Over to you, Dr. Satyamurthy.
Thank you, Dr. Ullas. I invite Dr. Muralidharan, Professor and Head of the Department of Cardiology at SRMC, Chennai, and Dr. Ilayaraja, who is Senior Consultant Cardiologist at Bilroth Hospital, Chennai. And I take this opportunity to invite our speaker, Dr. Ashish Nahar, who is Organizing Secretary of Annual Conference of IHR Society, and he is Consultant Cardiologist at Jupiter Hospital, Thane, and also visiting electrophysiologist at KEM Hospital. Without losing much time, I invite him to talk on the when does he use mexiletine and sotalol, in which situations he use. May I request Dr. Ashish Nahar, please.
Yeah, thank you, Dr. Ilayaraja, for a very kind introduction. And we could possibly make this question a little more democratic and say, when should we use mexiletine or sotalol for VT? So this talk is divided into kind of three parts, where in the first part I made first set of slides make a case for antiarrhythmic drugs still having a role in treating VT in structural heart disease, possibly even after an ICD implant. In the next few slides, I would probably point out to the VT syndromes that we deal with in the clinical situation, which is then easy to understand for the non-EP cardiologists, and then come down to where is the niche to use mexiletine and sotalol in VT in structural heart disease. So it is beyond doubt that ICD is required in VT with structural heart disease, whether you are dealing with an hemodynamically stable VT or an unstable VT. Presently, there is no debate that you should give ICDs, but it is not an open and shut case, because these people tend to get at least 5% appropriate shocks per year when they are symptomatic for heart failure. So one has to deal with this recurrent VT. And even a single appropriate shock effectively increases the mortality risk, whether it's related to the VT or whether it's related to the worsening structural heart disease. The mortality risk goes up, and if he gets more than one ICD shocks, then it goes up further. Plus, the shocks affect the mental well-being of a person. His ability to tolerate the shock and lead a normal life comes in question. And we do have questions how and when to initiate antiarrhythmic drug therapy. If one gets one shock, do you start, or when you wait for some more shocks? So all that is clinical experience and individual judgment. If you look at the use of antiarrhythmic drugs from this Medicare data from 2012, one can see that we are significantly underusing the beta blockers in these patients. So 2/3 of them, probably more, should receive. But we are required to use class 1 and class 3 drugs in almost 1/4 of the patients. And obviously our first choice is amiodarone, but some patients are on sotalol and mexiletine. So there is definitely a need to use antiarrhythmic drugs in these patients even after they receive an ICD. And there is a difficulty with these antiarrhythmic drugs, because only half of the patients can be on the same antiarrhythmic drug in the same dose over a long term. In fact, almost 1/3 of the times you may have to withdraw the drug, or have to reduce the doses of the drug, or may have to add some other drug. So antiarrhythmic drug use is still very much alive in this group of patients. And why do we say amiodarone is our first choice? Is because it is better than sotalol. So beta blockers are definitely more useful, but when you have to make the next choice, it is amiodarone, because it reduces the recurrent VTs in these patients. However, you should not use ICD. However, you should not use amiodarone in patients for primary prevention, even if they have a structural heart disease and heart failure. But using amiodarone is not so simple. It has its own problems, which means that first of all, you should use beta blocker before you add amiodarone. And even when you use amiodarone, the difficulty is that even with higher doses of amiodarone, you could have recurring VT. Amiodarone has a great discontinuation rate over long term, and very isolated situations you may have that amiodarone use is related directly to toxicity, which results in death. So Once again, you must look beyond amiodarone when you're treating VT structural heart disease. So probably what is more prevalent in the current literature is to try and ablate, and that's where Dr. Haigreve and Dr. Daljit brought that aspect out. Now, all the randomized controlled trials that you have in terms of ablating a VT structural heart disease post-infarct VTs, we probably have less studies in patients with non-ischemic cardiomyopathy. And these ablations have been done before the ICD is implanted to reduce the ICD shocks. They have been done when the recurring shock after an ICD is hemodynamically stable, so they prolong the time to the recurrent VT, and they have been done even when the VT is unstable and some benefit has been obtained. But presently, we are probably more concerned with this VANISH trial, where patients had a VT storm despite one antiarrhythmic drug, and there they compared the benefit of up-titrating amiodarone or adding mexiletine to doing an ablation. We do need to look beyond catheter ablation in these patients with recurrent VT after an ICD, because many patients are suitable to be brought to the cath lab because they are high risk for the procedure or they have severe heart failure. The ablation procedure itself has a limited success and depends on how you define the success. These procedures are very complicated and they can result in complications. And there are a lot of recurrences more in patients with DCM probably than in patients with ischemic cardiomyopathy. So ablation is definitely an option, but it is once again not everything in these patients with recurring VT after an ICD. And therefore, actually, although the VANISH study said that you can ablate better than escalating the antiarrhythmic drug therapy, I think if you read through the fine print, there is still very much a role for escalating the antiarrhythmic therapy. And that's because some of these points, every time the VT burden is not so much that you want to bring the patient to the cath lab, they could be successfully terminated with ATP, but they're recurring, so you don't want to have them. You may have a possibility to up-titrate the present dose of amiodarone or add mexiletine and up-titrate it. It may take time for you to organize an ablation procedure, so you will require antiarrhythmic drugs to come in. And then once again, your ablation procedure may not be entirely successful to take away all the VTs and you may need antiarrhythmic drugs. So even in the VANISH trial, I think there is a room for antiarrhythmic drugs. What the VANISH trial really tom-toms about is that the primary outcome was better. And that primary outcome is a composite of death and appropriate therapies after 30 days. And I think there is something that one must understand, that you have a significant period after the ablation in the first 30 days where they still keep on having the VT recurrences. And it is only after 30 days that you're able to quiesce these VTs. So you need antiarrhythmic drugs even after ablation in the initial period. Of course, the difficulty when you use antiarrhythmic drugs in this situation is you can make the VT slow and then it can tend to be incessant. So once again, VANISH trial does advocate ablation to escalating the antiarrhythmic drug therapy, but if you read through the fine print, the benefit comes a little late and therefore there is room for getting an antiarrhythmic drug therapy. I switch gears here and just outline the VT syndromes which are recognized by the electrophysiologist and which could be of some help as a non-EP cardiologist tries to understand this. Now, we have a habit of trying to stop or taper away the antiarrhythmic drugs after implanting an ICD. You want to hold back cordron because of its toxicity, and probably there is a role for sotalol here. You can probably use sotalol as a first-line therapy if the ejection fraction permits. If the ejection fraction is good, you may hold back cordron till there are recurrences, and therefore sotalol can have some role in suppression of the VT. The second kind of a syndrome that you may deal with is there are VT recurrences, but they are quite well treated with the device therapies, and they are not in clusters, but they happen with the gaps of few days, but they are recurrent. And you would ideally, as we said initially, not like to have even too many appropriate therapies because they do affect the cardiac function and the mortality. But for example, if you have frequent ATPs or you have very fast VTs, you may use antiarrhythmic drug therapy to reduce the VT recurrences or to make a fast VT slower so that it is more amenable to the ATPs. So once again, there is a room for antiarrhythmic drug therapy. The only thing you must remember is probably not combine same class of drugs, but combine probably a class 3 and a class 1 drug. And there is there comes the example of one of the drug that I need to speak about, amiodarone plus mexiletine. Mexiletine is not now available to us, and therefore one should remember that one can combine amiodarone and mexiletine, and there has been similar experience with combining some other class 1 and class 3 drugs to bring about the same benefit. The third VT syndrome that you might kind of experience is the situation that probably Daljit said, the VT storm. So once again, storm has been defined previously as more than 3 episodes in a day. So it's clustering of those VT episodes, and there could be a need to have antiarrhythmic drugs here also. Ablation is useful only when it is successful. A partially successful ablation may be still a difficulty, and these patients are usually sick. Most of the studies are from very capable centers, and for a routine practice, one still needs to use antiarrhythmic drugs because there is a room to escalate the same amiodarone. If it is in a lower dose, there is a possibility to add amiodarone if some another drug is being used in a VT storm patient, and there is a room to add mexiletine and up titrate it. So mexiletine does have a role in a situation when amiodarone is already on to be added as one more therapy to get control of the VT storm. This is a little difficult subset, the fourth subset of VT syndrome, where the VT is too slow, and as a result of it, it is incessant and can lead to heart failure if untreated. So here, you can program the ICD, lower down the detection and try to terminate the VT, but escalating antiarrhythmic drugs sometimes may not be useful because here you may just slow it further and make it more incessant, and ablation probably would be a better strategy in this case. So I think these are the different scenarios in which the VT, recurring VT presents after an ICD, and you must identify them and try to see where your niche for pushing in antiarrhythmic drugs. Mexiletine, I think, is a good drug because every antiarrhythmic drug has a great negative inotropic effect and a torsade potential, and therefore mexiletine is one class 1 drug which is the least torsadogenic. And there has been old evidence which suggests that amiodarone plus mexiletine does give a short-term arrhythmia control better. It can be up titrated to a dose of almost 600 milligram per day, but the average dose usually used is about 400 milligram. It is probably preferred in patients who are older in age and have more CKD. These are probably the patients you don't want to bring to the cath lab easily. But the long-term efficacy of using mexiletine continuously is still not very clear. But in short term, adding to amiodarone would make sense. Where specifically, if I were to point out, it could be that you have ablated these patients and are unsuccessful with the optimal medical therapy where you may add mexiletine to amiodarone. It could be a situation where you use lignocaine in addition to IV amiodarone and found some benefit, and then now you want to switch to an oral class 1 drug where mexiletine can be added after switching on lignocaine. And in unsuccessfully treated patients with optimal medical therapy, once again, who do not qualify for RF ablation, whom you don't want to bring to the lab because of the feared complications, in such patients, you may add mexiletine to amiodarone. So these are specific clinical situations where you should consider adding mexiletine to amiodarone. The good thing about mexiletine is that it is reasonably well tolerated, and unlike some other antiarrhythmic drugs, you don't have a great need to discontinue the mexiletine. The tolerability is very good, and I can recent publications which have used mexiletine for as long as 8 months after that VT storm or events where added to amiodarone. It could be continued for that longer period with a significant reduction in the different VT events. So amiodarone plus mexiletine does seem a good combination, and it seems opportune currently to discuss with the availability of mexiletine in our situations. There is another use of mexiletine in a VT situation. All of us are very well in news that mexiletine is useful to treat patients who have long QT3 syndrome, but there are other long QT patients where bradycardia does turn to be a problem. So even if they are LQT1 or LQT2, if they get into bradycardia, then they have more bradycardia-induced QT prolongation and therefore a risk of VT. So in these patients, it can be combined with lignocaine. Mexiletine can be added, or mexiletine can be used
I'm
even in
extremely
other
sorry to
LQT.
interrupt, sir. I'm
Yeah,
extremely
it will
sorry
take
to
me
interrupt, sir.
few minutes.
Thank you so much, sir.
Yeah,
Thank you.
thank you. Sotalol is again more useful in patients who have ischemic cardiomyopathy than in patients who have non-ischemic cardiomyopathy. One has to be careful to use it in patients who have not more than a moderate LV systolic dysfunction. When you deal with cardiomyopathies, dilated cardiomyopathy and arrhythmogenic right ventricular cardiomyopathies are the one where you use sotalol. You do not use it in hypertrophic cardiomyopathy because of a possibility of torsadogenic effect. You require higher doses of sotalol, almost 320 milligram per day, unlike as in atrial fibrillation. And therefore, it is recommended that you should start this preferably in hospital. Low doses can possibly be started in outpatient, but high doses need to be started and up-titrated in the hospital. And it should be avoided in patients who have decompensated heart failure and have severe LV systolic dysfunction because of its negative inotropy. Sotalol can be used in patients who have frequent PVCs and known structural heart disease, but its role in patients who have structural heart disease and recurrent VT is a little doubtful. And the reason that has come into doubt is, I'll conclude with this slide, is where apparently amiodarone plus mexiletine was better, but using sotalol led to increase in VT recurrence and ICD shocks as compared to amiodarone. So this recent meta-analysis and systemic review seems to put sotalol in a bad light. So I would say that where you have no structural heart disease and PVCs, or you have VT in structural heart disease and you're given an ICD and he has infrequent shocks, I think sotalol is useful. So this is my concluding slide, where I would like to say that escalating antiarrhythmic drug therapies plus catheter ablation is the first thought that we should come in mind. Escalating amiodarone is limited by its side effects. Ablation use is limited by its high recurrence rate. So mexiletine combining with amiodarone is good in short term. The long term aspect of it might still need to be clear, but the good thing is it has a good safety profile. And sotalol is good for PVCs with no structural heart disease or post AICD when the shocks are infrequent and you want to hold back cordon. I think there sotalol has a role. You got to be careful that these are not the patients who have a heart failure or a very severe LV systolic dysfunction. I think I'll end here and I thank you for your patient hearing. Thanks.
Over to the moderators, please.
Hi. Dr. Murali, would like to make any comments?
Hi, Nabar. It's a very clear, lucid presentation of use of these drugs. Particularly, it's very useful for many of our viewers, wherein it's slowly becoming amio is the only antiarrhythmic for most of the VTs in our day-to-day practice. Like things like we are using penicillin, Peridure for every STD, we are using amiodarone left and right. Time to think of all these drugs. You have presented very nicely. One thing is like in amio-induced QT prolongation, do you think particularly mexiletine combination will be of an effective therapy or changing over to mexiletine?
In case of QT prolongation, which is drug induced, there is not much evidence that.
With amio, no. In arrhythmia reduction post ICD, when the QT is prolonged on amiodarone, would you like to change over to mexiletine on such situation, or stop amio and change over, or combine mexiletine along with amio?
So if amiodarone is responsible for QT prolongation and it is in the torsadogenic range, if the QT is more than 540, 560, then obviously you'll have to cut back the dose of amiodarone and see if that helps, because amiodarone still remains your first choice. Unless you absolutely have a non-sustained VT runs, then you take it away completely. But if it is only a QT prolongation, you might want to cut back on the amiodarone and see if that is good enough. But if you have non-sustained VT runs, then probably you would obviously get out of amiodarone and then you need to use something else. So if it is a singular drug that you want to use, probably you can use mexiletine and beta blockers. Or you can, if somebody has a ICD only, then you can leave on beta blockers and use mexiletine only if there are ICD therapies that are coming in. So you would scale it according to whether the ICD is fired or firing, or whether the ICD is silent. You always have the back of the ICD. If there are therapies happening repeatedly, then you would add a mexilatin to beta blocker. Otherwise, you might just cut back the cordon and leave on beta blocker till the QT comes back to normal.
In which situations you use intravenous mexilatin?
So intravenous mexilatin we don't have. We have only the oral form of mexilatin, and some thinking that if your lignocaine is working, lignocaine is obviously used when you think that ischemia has a role in the recurrence of the VT, and you use lignocaine and you find that the lignocaine helped you to control the VT in addition to amiodarone or as only drug, then it seems sensible to think that if you have to switch to the oral form after stopping lignocaine, then mexilatin being from the same class seems to be the right thing to do.
Because now companies planning to bring intravenous mexilatin. Initially, if you remember, in the early 80s, they introduced intravenous mexilatin. We used to use in acute myocardial infarction when there is a lignocaine sensitive tachycardias.
Rather, we can call mexilatin as a oral lignocaine. Is that not, sir?
Yes, I think so.
Can I have, sir, 1 or 2 minutes?
Yeah, please, why not?
Yeah. Thank you, sir. So good evening all, and it's a great work by CSI Chennai chapter and Dr. Ullas for having this cardiac rhythm digital meet India, and I wish him congratulations for the next consecutive days. And it's a great presentation by Ashish Nabar. He covered everything. But this is a COVID era, and we had a lot of issues regarding this acquired long QT interval syndrome. So if already a cardiac patient on certain drugs, and then if they develop a COVID disease, then how to treat them, especially in this kind of acquired long QT interval syndrome disorder. In the COVID pandemic background, the mexilatin really plays a major role. And another thing, though the frequency of long QT interval monitoring, there are certain protocols laid by Indian IHRS protocols. But when honestly we follow, that is not really helpful actually. I need input from others, because the basal QTC versus the linear relationship with the possibility of developing torsades, or the baseline showing some prolonged QT, but when they go on drugs, but they are not developing the clinical disease as such. So all those things I am leaving it to for the senior consultant to have their views. And then regarding one comment regarding Dr. Muralidharan sir said. So when you want to add, kind of amiodarone showing a prolonged QT interval syndrome kind of picture, and what is the role of mexilatin, something like that. But references says clearly that among the class 3 drugs, amiodarone is the one drug that can, despite showing in the surface ECG prolonged QT interval, that can reduce QT dispersion. And there is a good study offhanded, I could not remember the author, quinidine versus amiodarone, and that's why among the class 3 drugs, despite upper limit of QT interval, amiodarone can be safely continued because that reduces QT dispersion. But as Dr. Ashish Nabar mentioned, that the amiodarone can be safely combined with the mexilatin, or since we are talking about mexilatin one drug that can be safely combined with the beta blocker, amiodarone, and other class of drugs. And finally, regarding the sotalol, that's a good molecule. But regarding one word about chirally pure molecules, the concept of chirally pure molecules, and then enhancing their effectiveness, in promoting the pharmacokinetics positive way, still a fascinating subject. In any molecule, they have not tested success. In SWOT trial, they used D-sotalol. It's a negative study. From that moment onwards, still we are using D and L steroids containing sotalol only. And now that has its own limitation. But adding the drugs, escalation drugs, combination, all those things beautifully explained by Dr. Ashish Samar. Once again, thanks for the opportunity, and I really congratulate Dr. Ullas and the CSHN chapter for the subsequent or consecutive days. Thank you, sir.
You are perfectly right. In fact, AMIO, independently QT prolongation, rarely associated with ulcers because the QT dispersion is not significant. In fact, if you see, there are literature where they looked at not only QT interval, but T peak to end. T wave peak to end will indirectly show the QT dispersion part. That is one thing. That's the main thing. Because of the varying effect on the endo, epi, and the M cells, this effect. So, well then. But the problem is, AMIO causing QT prolongation is not that dangerous. But AMIO, QT prolongation, along with other factors coming in, metabolic abnormalities or any other thing, can still precipitate arrhythmia. That's a problem. So, in those situations, we are worried about the QT prolongation. But this is a wonderful point, and the T peak to end is often not looked seriously by many physicians. But that's an interesting measurement which will tell you exactly whether the QT dispersion is good or bad.
Yes, sir.
So thank you, everybody. Actually, there's so much of a discussion on QT interval, and Ilaraja raised this issue about in the COVID era, the medications what we have been giving, some QT prolongations. We have an exclusive day for the QT prolongation and QT interval related issue in the coming days. Dr. Ashish, as usual, we learned a great deal from you, especially as our Murali was talking about, we need to be looking at specific indications apart from omidron, looking at sotalol and mexiletine to use for the treatment of VT. So, ladies and gentlemen, I would like to announce here that it was a huge success day one of this Cardiac Rhythm Council. I am looking at the numbers here. It is crossing 350. It's a huge success. Thank you, everybody who had tuned in. And I request everybody to be staying connected with us for the coming 5 more days rather, every day starting from 6:30. And thank you, everybody. Especially the last but not the least topic was so very useful. I believe looking at the comments and the responses from the audience. So we take leave from today, but we are joining tomorrow. Thank you very, very much, and happy evening. And see you people tomorrow. Thank you very, very much. Bye-bye.
Bye-bye.
Thank you, Ullas. Thank you. Bye.
Thanks very much.